Welcome to this explainer. Now, you've definitely seen an ECG monitor before, tracking the rhythmic, pulsing electrical currents of the human heart. But today, we're going way beyond those basic beeps and jumps. We're going to decode the exact physical map these machines are drawing in real time. Basically, we're taking all the mystery out of the electrocardiogram.
We've all seen those dramatic, intimidating, squiggly lines on medical monitors in movies, right? Usually they're accompanied by some tense beeping sound right before a massive medical emergency. But the thing is, those lines aren't just some random indicator of life. They are a highly precise 3D map of cellular biology in action. So today, I'm going to give you the decoder ring to actually understand what they mean, and we'll see exactly how those squiggly lines save lives.
Section 1. Decoding the heart's electricity. Okay, to really understand this machine, we've got to start right at the foundation, a single heartbeat. To grasp how an ECG actually works, we first have to look at the difference between heart cells at rest and what happens when an electrical wave of depolarization passes through them. At rest, heart cells are negatively charged compared to their slightly positive outside environment. But as a heartbeat kicks off, a wave of depolarization sweeps through. Suddenly, those cells become positively charged, which leaves a slightly negative charge in the environment directly outside of them. Just imagine this electrical wave flicking the charge from a resting state to a depolarized state, sweeping right across the heart muscle.
Now, this difference in charge across the cells creates something absolutely crucial, a dipole. If we could magically freeze that wave of depolarization halfway through the heart tissue, we'd see half the cells are positive and half are negative. That creates a physical difference in charge, two electrical poles, or a dipole. We map this dipole out as a literal arrow, an electrical vector, pointing directly toward the positive charge on the outside of the cells. And this vector? It's the secret language the ECG machine is actually reading.
Moving right along to Section 2, dipoles, vectors, and deflections. Let's see how that physical vector translates into the actual lines we see bouncing on the screen.
The fundamental rule of this whole explainer is so simple. When a dipole vector points toward a positive electrode, the ECG tracing goes up. That's a positive deflection. Conversely, when that vector points away toward a negative electrode, like during the repolarization phase when the heart resets, the line goes down, creating a negative deflection. And magnitude absolutely matters here. The bigger the dipole, meaning the stronger the electrical difference, the larger the deflection on the screen. Once the entire tissue is fully depolarized, there's no longer a difference in charge, the dipole completely vanishes, and the line just returns to a flat resting state.
But here's the catch. Human biology almost never lines up perfectly with our physical equipment. When an electrical wave hits at an angle, the physics gets a little tricky. We have to break that vector down into two parts, one parallel to our electrodes and one perpendicular. The size of the deflection on the ECG always, and I mean always, corresponds only to that parallel piece going toward the electrode.
And this brings us to a genuinely wild fact. If the electrical wave travels completely perpendicular to our electrodes, the line stays flat. It hides the activity entirely. Seriously, think about that. You could have a massive wave of electricity firing straight up through the heart tissue, but if your positive and negative electrodes are placed horizontally, the machine registers absolutely nothing. Zero deflection. This is exactly why relying on a single pair of electrodes is never, ever enough for a true medical diagnosis.
Section 3. From electrodes to leads. We've mastered the building blocks using just one pair of electrodes, so let's scale this up to see how a full medical setup functions.
In a standard hospital setup, medical professionals attach 10 physical electrodes directly to the body, utilizing the limbs and the chest to capture the heart's transverse and coronal planes. 4 of these go on the limbs, 1 on each arm and leg, though the right leg is really just used as a neutral grounding wire. Then, 6 precordial electrodes, labeled V1 through V6, are wrapped around the chest. These chest stickers give us a perfect horizontal slice, the transverse plane, of the heart's electrical activity. But here is the crucial point. Those 10 physical stickers actually combine to give us a grand total of 12 distinct viewpoints, creating the famous 12-lead ECG. Notice the difference in terminology we're using here. The electrodes are the physical stickers you put on the skin. The leads are the virtual viewpoints the machine mathematically calculates by comparing those stickers against each other. By mathematically combining these 10 electrodes, doctors effectively set up 12 different camera angles to watch the heart in 3D. First, the 6 chest leads view the horizontal plane. Next, the augmented limb leads, AVR on the right arm, AVL on the left arm, and AVF pointing down to the foot, capture the vertical plane. Finally, the machine calculates 3 bipolar limb leads. For example, lead 1 uses the right arm as negative and the left arm is positive to form a vector looking directly right. Together, these 12 perspectives leave absolutely zero blind spots.
Which brings us to Section 4, diagnosing the heart's regions. So why exactly do we need all 12 of these specific camera angles to look at one single organ?
Well, because the exact same wave of electricity looks completely different depending on which camera is recording it, and that reveals any hidden roadblocks in the muscle. Take the main contraction of the heart, known on the ECG as the QRS complex. That exact same depolarization wave might look like a huge negative dip in chest lead V1, perfectly flat in V3, and a massive positive spike in V6. By comparing all these views, a doctor can visualize the exact three-dimensional path the electricity is taking, and more importantly, they can see if that electricity is being forced to detour around damaged or diseased tissue. As this incredibly useful breakdown maps out, specific groups of leads monitor specific physical regions of the heart. This allows doctors to trace an abnormal line directly back to the exact diseased artery. Issues in leads 2, 3, and AVF point straight to a problem in the inferior wall of the heart, tracing back to a blockage in the right coronary artery. Problems in the lateral leads, like lead I or V6, point to the left circumflex artery. And if the septal or anterior leads, V1 through V4, show strange deflections, the culprit is likely the left anterior descending artery. It's just pure elegant deduction.
It's absolutely amazing how a few basic laws of physics transform simple stickers on the skin into a life-saving 3D map, isn't it? It really leaves us to wonder what other invisible forces inside us are just waiting to be decoded. But for now, you know that an upward spike isn't just a heartbeat. It's a vector of positive electrical charge marching directly toward a strategically placed camera. You officially have the decoder ring. Thank you so much for joining me on this explainer, and keep questioning what's hidden just beneath the surface.